ASCO 2015 coverage. Thomas Baldrick, joined now by Dr. Aaron Vinik. He is from the Eastern Virginia Medical School, and he is here to talk about the ELECT study. Thank you, sir, for coming by.
Thank you very much for having me. It's a real pleasure.
So you're looking at solutions for patients with neuroendocrine tumors. What can you tell us about this as an overview?
Just briefly, neuroendocrine tumors embrace gastrointestinal tumors such as carcinoid and pancreatic neuroendocrine tumors. The major therapy for both pancreatic neuroendocrine tumors as well as gastrointestinal has been peptide therapy. And the peptide that has been used is somatostatin. Unfortunately, however, the existing forms of somatostatin, there's about a 40% escape from the symptom complex. And the symptom complex embraces flushing, diarrhea, abdominal pain, and cardiovascular insufficiency. The intent of the ELECT study was to determine whether or not treating people with a new form of somatostatin, Lanreotide or somatulin, compared with placebo, would actually reduce the escape from control. And what the study in essence shows is that the reports are twofold. One has been reported by Martin Kaplan in the New England Journal of Medicine to show that not only does the drug control symptoms, but it also controls tumor growth, and it slows the rate of tumor growth. And that has never been claimed or shown for other somatostatin analogs, nor are they approved for that. So this is a major breakthrough. The first form of the ELECT study, which I reported last year in the Journal of Clinical Oncology, showed that you could control the symptom complex and you could get a significant 30 to 40% reduction, almost paralleling the failure that occurred with the former somatostatin analogs. The question here at this meeting, the poster that I showed this morning, was to say, were there individual components in the patient population, the 115 people who were randomized 59 and 56 to Lanreotide or placebo, that we could identify that would either enhance the response or negate the response. And it transpires that yes, there are. Is that if you have a BMI over 30, you're unlikely to respond, and that may be simply a question of dosage. If you're a male, you are more likely to respond. If you had the condition relatively short term, you are more likely to respond to the drug. And so that there are criteria that would emerge as to whether or not we could predict responsiveness.
What do you see the clinical impact of this being?
I think it's twofold. I think right now is the notion generated from previous drugs of this class was that they could control symptoms, but they were relatively ineffective for controlling tumor growth. It now emerges that in the somatostatin era of therapy, that we've markedly prolonged progression-free survival. Long-term outcomes are better in the somatostatin era. And what's more is that we have a drug that it appears that will recapture the people who have failed and escaped therapy. So I think it just behooves us now is to educate our practitioners out there to the role, the dual role. The one role is for controlling tumor growth, prolonging survival, prolonging progression-free survival, and the other is the control of the symptom complex.
Now, what might you do in further investigation of this?
The attractive thing about this is that after peptide therapy, there's now directed therapy. And the directed therapies have come from two classes of compounds. One are the mTOR inhibitors, such as afinitor. The other are the tyrosine kinase inhibitors, such as Sutent. What has been shown, only because people were never taken off their somatostatin, is that it confers an advantage for the people who are trying the new directed therapies combined with the peptide therapy do better. So what I anticipate the next stage will be is how can we now improve on the results that we've obtained so far by doing combination therapies of the different pathways involved in causing tumor growth and proliferation.
Well, thank you for coming by. Stop back and let us know when you have something else, would you?
By all means.
Thank you, sir.
Thank you.
Appreciate it. Good
Okay.
luck.